Brilliant. Well, I mean, welcome everybody this morning. I hope you've all been able to log in okay over the last 30 seconds or so. We're having a fantastic discussion today about the Women's Health Strategy, which is out for consultation by government. I'm Dr. Lisa Cameron. I'm MP for East Kilbride, Straven and Lesmahagow, which is up in Scotland. You can probably tell from my accent. I also chair in Parliament the All-Party Parliamentary Group for Inclusive Entrepreneurship, and I'm extremely keen to support and champion those from ethnic minority backgrounds, women, people with disabilities, and others from areas of protected characteristic into business, and to make sure that the UK doesn't leave anyone behind and that everyone can contribute their potential to our economy. So I'm really looking forward to the discussion that we have today, which is about Mind the Gap and achieving gender parity. We have some fantastic speakers, and I'm going to let them introduce themselves for a couple of minutes, and then we'll have some questions, and then we'll have a Q&A. So please remember to put your questions into the Q&A, into the chat for our Q&A, because we want to have as many questions from those participating today as possible, and to have an extremely thorough discussion so that we can be feeding into the government's policy consultation from today's meeting. So introductions briefly to start with. First of all, we have Dr. Jenny Douglas, who is chair of the Black Women's Health and Wellbeing Research Network. Jenny, do you want to say a bit about yourself and the work that you're doing?
Okay, thank you very much, Lisa, and thank you for inviting me. I am a senior lecturer in health promotion at the Open University, and I'm chair and founder of the Open University's Black Women's Health and Wellbeing Research Network, which has been running for 10 years. This is our 10th anniversary this year, and we've been a kind of forum for knowledge exchange. So we had our first conference in June of 2011 when we formed, and we've had a lot of seminars and workshops since then. And during the last few months, we've had some international webinars to have conversations with people in the USA, and we have one in a week's time with people from the Caribbean and Canada to talk about Black women's health. That's
brilliant, real international feel, and congratulations on your 10th anniversary.
Thank you.
Our next panelist is Shaista Gohir, OBE, who is the Women's Voices Lead for the Royal College of Obstetricians and Gynaecologists and chair of the Muslim Women's Network. So welcome, and can you tell us a bit about the work that you're doing, and I suppose how you want to contribute to these issues in terms of gender parity?
Hi Lisa, as you mentioned, I'm the Women's Voices Lead at the RCAG, so I chair a strategic committee and involved in lots of other committee work as well. I'm also the co-chair of Muslim Women's Network UK, which is a national charity. We've got a national helpline as well. We've got an MWN hub where people can sort of go on, anyone can register and try and reach women on there as well. Recently set up a global charity aimed at women and girls called Nissan Global Foundation. And of last week as well, just been newly appointed as Associate Non-Executive Director at the University Hospital of North Midlands. So quite a lot going on at the moment.
Yeah, you're extremely busy. Well, thank you so much, and we look forward to your contribution. And I wish I had just said RCOG, because it would have been much easier than trying to state all about the Royal Colleges and the medical terms that I managed this morning. Our next panelist is Sara Gorton, who is Head of Health at UNISON. Welcome, Sara.
Thank you very much. Yeah, so I'm Sara Gorton. I'm Head of Health at UNISON, but that doesn't mean I have any health qualifications. It means I look after people who work in the health sector. So I lead the work of UNISON and the other NHS trade unions in the negotiations that we have with employers and policymakers about workplace issues and pay terms and conditions for health workers. So UNISON more widely has, with the UK's largest trade union, and we represent members in sectors that are predominantly dominated by women workers, so education, where we look after teaching assistants, business administrators and other support workers, local authority and care, in particular, a very growing number of people working in that sector, and a sector that's attracted a lot of attention. So I think one of the things we're really keen to see is to learn the lessons from the pandemic, which shone a light on some of the disproportionate impacts faced by women workers in those sectors. And we'll be looking to build on that through our response to the women's health strategy. That, coupled with the bargaining work we've been doing on issues like flexible working and better workplace women's health policies. So I'm looking forward to speaking about that today.
Oh, fantastic. And I know that of the extensive work that you do right across health. And actually it's a blast from the past for me, because I was a member of the Scottish Terms and Conditions group with Unite prior to coming into Parliament. So I know just, the detail that you'll have to go into in terms of employment issues for members of staff in the partnership negotiations. So thank you so much for lending your expertise. Our next panellist is Dr. Anita Mitra, the Gynae Geek, as she's more commonly known, and is a registrar in obstetrics and gynaecology. Welcome, Dr. Anita.
Thank you. Thanks so much for inviting me today. So as you said, my name's Dr. Anita Mitra. So a little interesting fact about me is that my surname is the Greek word for uterus, which is interesting because I'm an obstetrician and a gynecologist. So I've been a doctor for 10 years. I work for the NHS. I'm based in London. I'm also an academic researcher. So I have an Imperial College academic position as well. I did my PhD there a few years ago. And I also appear online as the Gynae Geek. So I noticed a few years ago that there was just so much hunger for reliable evidence-based information. So I started it on Instagram, and I also 2 years ago published a book which is also called The Gynae Geek, Your No-Nonsense Guide to Down There Healthcare, which is a real back-to-basics guide, all the things that I think everybody needs to know about gynecological health.
Fantastic. And that's, you were just born to be in this profession, obviously, with your second name. Our next panellist is Rebecca Taylor, who's a policy manager at Endometriosis UK. Welcome, Rebecca. And
Thank you.
Can you say a bit about the issues you've been working on?
Sure. So I lead on policy for Endometriosis UK, which is the UK's largest national charity for people with endometriosis, which, for those of you who don't know, is a menstrual health condition that affects 1 in 10 women or those assigned female at birth. And it's about as prevalent as diabetes, but nowhere near as well known. So I joined the charity in March, and we've just done actually a small survey on the impact of COVID on women with endometriosis in England for the Women's Health Consultation. So we'll be putting in some data on that.
Fantastic. Thank you so much. As you can see, we have real expertise from across a wide variety of sectors today, and really with a key focus on women's health for that strategy document. So I'm really looking forward to hearing more detail from the panellists. But please, when you're joining us, do remember that you can use the chat function and add some questions, so that when we have our Q&A following from the initial questions to the panellists, that it's as participative as possible today, and we have your thoughts and your questions and responses that are all going to be so fundamental to making sure we have a comprehensive strategy. So the first question that I have here is for Rebecca Taylor, and it's about endometriosis. It devastates the lives of over 1.5 million women and their families. As an MP, actually, I have a lot of inquiries in my mailbag about this condition. What changes to the healthcare system do you believe are needed to empower women to manage the condition, and why? Thank you, Rebecca.
No problem. Well, it's probably easiest to look at this in terms of barriers that people face and how to, get over them, dismantle them. So as I mentioned in my brief intro, it affects 1 in 10 women or those assigned female at birth. And currently it takes on average 8 years to be diagnosed with endometriosis, which hasn't improved in a decade, which is quite shocking because obviously delays in diagnosis mean delays in getting the right care. And it's also, this can also mean sort of years of GP and hospital appointments that don't identify a cause for the symptoms, which is not only distressing to the person, but a complete waste of NHS resources as well. So the first barrier is awareness and understanding of the condition, which applies to the public, but also in some cases to healthcare professionals. So, if a girl or woman doesn't know sort of what a normal period is, they may not realise that, for example, the really bad pelvic pain they're getting isn't normal and is actually a sign of a medical condition. So that can be a barrier in seeking assistance. This is being overcome in England, at least for future generations, because menstrual wellbeing education is now in the national curriculum. It started last September, so that's a good development. Obviously, it's not backdated. You can't backdate education. And we know from our own research and from speaking to those in the endometriosis community that not all healthcare professionals, including GPs, gynecologists and A&E doctors, who are probably the most commonly seen, have good knowledge of endometriosis and symptoms. So we hear stories of women presenting with symptoms being told it's just part of being a woman and maybe you've got a low pain threshold. So that's a second barrier to work on. Which
women never have a low pain threshold, by the way. So we know that.
Labour, hello. I would agree with that. And this barrier can be overcome by obviously improving healthcare professional knowledge of the condition. That requires working with, Royal Colleges on their curriculum. And it's also in the NICE guide. There's a lot of NICE guidance about endometriosis, and it's also in the NICE quality standards that healthcare professionals should be able to recognise the symptoms of endometriosis. And then we come to barriers within the healthcare system. And the barriers are actually very similar across the UK, the different healthcare systems, but I'm sort of going to talk more about England here. They're not hugely different in other countries, just because obviously the consultation is Department of Health and England is their remit. So, at the moment, people can have a long wait for referral once they're referred, and COVID has made this worse, unfortunately. So when the GP correctly refers on someone with symptoms of endometriosis, there can be a wait. And there's also an issue that not all gynecologists are familiar with endometriosis. So if someone is referred to someone who isn't that familiar with the condition, that can also delay things. And there are delays in getting laparoscopy, which is a key form of keyhole surgery, which is the only definitive way to diagnose the condition. It'd be great if someone could come up with a non-invasive definitive method. So there's a few things here, but there is one fairly easy solution. No, it's not an easy solution, but it's an obvious one, which is to implement the NICE guidance properly. So there's 2 lots of NICE guidance on endometriosis. One is a guideline, and the others are quality standards. They're both fairly recent, 2017-18. And they are adopted, but they're not fully implemented anywhere in the UK, including in England. And there's a number of things. So the first thing to do is to get them implemented properly. And this would include a number of things. I'm not going to list them all, otherwise I'll be here all day. Managed clinical network for endometriosis care in every area, prompt onward referral, and developing the role of a gynecologist with a special interest in endometriosis, which is a role that is established by the NICE guidelines, but hasn't actually been sort of defined or appointed. As far as we know, there are no appointments to that role. Giving women access to an endometriosis specialist nurse, this is really valuable. And then other things like referring those with deep endometriosis to a specialist centre. There are specialist centres that exist. They're accredited by the British Society of Gynaecological Endoscopy. There are about 55, I think, within the NHS. They're mostly within the NHS. So you know, it's kind of all there in the NICE guidance. There's a few things that need updating, like access to pain management, because there's been a recent guideline on chronic pain, and integrating mental health support. So there's a few things that maybe need to be updated, but getting the NICE guidance fully implemented it's where to start. But part of that is that capacity probably doesn't match clinical need in all areas. Hence, I mentioned that there were delays before COVID in relation to people getting referred on, getting laparoscopy, getting surgery, getting gynecological appointments. So we would sort of recommend doing a kind of stock take just to see, you know, it varies from area to area, to see where there are the gaps and where, you know, perhaps there might need to be more diagnostic capacity, those kind of things. So, you know, it's kind of pretty much all there in the NICE guidance. So it just needs to be a lot of work done on that. And the key thing is the diagnosis, reducing diagnosis time. Okay. Because if you can get that right, and then people get the care they need earlier, yeah, it's going to solve a lot of problems. I mean, for example, people with endometriosis often say, you know, that they report that they would like psychological support, but it's not because they've got mental health problems per se. It's the distress of having symptoms not managed properly and not being able to sort of live the lives they want that leads to, you know, sort of depression or anxiety, those kind of things. So there are, not I won't say simple solutions, but we kind of know what needs to be done. We just need to get it implemented.
Yeah, no, that's so valuable. And I'm just thinking, as chair of the health group in Parliament, that perhaps we could be linking with other all-party groups to bring these issues to government recognition, more so that perhaps the NICE guidelines are there, but they're not being implemented, and the care isn't there in every area. That's something that perhaps we could all also be asking our MPs to raise, and to find out what's happening in their area, to see where we need to improve for women's health. So thank you for your very thorough response, and I'm sure we'll come back to some questions. I see some in the chat already linked with the information you've given. The second question is for our Gynae Geek, Dr. Anita. It says the internet is flooded with poor quality and misleading information about women's health. Why can it be so difficult for women to access reliable information, and where can they find it? So it's really hard, because sometimes if the information you're reading is accurate or not, or if it's misleading, and that can be upsetting, but also, you know, I suppose at one end of the extreme it could also be quite dangerous. So how can we tell the information is reliable? Where should we go?
Yeah, I think it's a great question. And so, as I mentioned in the introduction, so I run an Instagram account and I wrote a book, and you kind of think, well, why does a doctor need to do that? They've got all day to give information to patients. Well, I just noticed through speaking to patients in the hospital, there was just such a hunger for information, but people didn't really know where to get it from. And so I did actually, as a social media user myself, notice that there was this conversation opening up about women's health online. And I did notice that people were starting to use social media platforms as an education tool. And so I thought, okay, I'll give it a go. I just thought probably it'd be my mum and my friends reading my information, but actually I just saw that so many people wanted to know things, people were really engaged, wanted to hear more. And I think that comes from the fact that there isn't a lot of accessible and engaging information out there. I think if we look at, for example, the information leaflets that we have to give people about contraception. Now, the contraception leaflets haven't really changed for many, many years. And in fact, the people that I'm giving these leaflets to, their mums probably were given the exact same leaflet. And I think that, you know, over these several decades, the way in which we impart information and the kind of information people want to know has changed. And it's great to see that people really want to engage in learning about their own health. But it's not actually just young people. I thought it was going to be kind of the more sort of like late teens, 20s demographic, but actually it's over all age ranges. And I think it's really nicely demonstrated by the fact that about a year ago now, I received a message from a lady in her 50s who said to me that she was just recovering from a hysterectomy. And she was very grateful to me because I had written a post that I posted on Instagram about bleeding after the menopause. She didn't know that this was something abnormal. She went to her GP and she actually ended up being diagnosed with endometrial cancer. And that was why she'd had a hysterectomy. So I think that's a really tangible demonstration of the fact that people are actually going to the internet for information. And I think that part of that stems from the fact that we're not taught about these kind of things at school. I think from my own education about gynecological health at school, I understood that a period was an egg cracking and that was the contents coming out. You know, this is me. I always wanted to be a doctor. I was quite engaged in this kind of thing, and I just didn't understand. So I really don't judge anyone for not understanding. And I think that also we have quite a short time with a healthcare professional. A lot of patients say to me, oh gosh, I've been trying to get referred to you for years. And then when they actually come to see me, I have 20 minutes. Now, I know that GPs have much less time, but I have 20 minutes to ask somebody about something that has probably been going on for several years, is causing them a great deal of anxiety. They feel embarrassed to talk about. They may be embarrassed to ask me questions. People often say, I know this is a silly question, but it's never a silly question. And then I have to think about arranging investigations, maybe review investigations, explain a diagnosis, discuss the treatment options, and then make a decision about where we're going to go from here in 20 minutes. And I've actually found that there's often quite a discordance between what the patient wants to know and what the doctor actually says. Now, I can tell you everything in a textbook about, for example, endometriosis, as we've already talked about. But is that what the patient actually wants to know? Often not. And that is something that I personally, as a doctor using social media, have learnt a lot about. Patients will not always say what they think about what the consultation was actually like, but social media has given everybody a voice, and it's very easy to write a post on social media, but it's very difficult for that same person to come to me and say, well, I didn't really understand anything that you told me. I didn't like the way that you spoke to me. I don't think that you really listened, and I don't think that you really addressed my concerns. And that is something that I'm seeing time and time again from conversations that are happening online. I think there are some really, really great online accounts and great places that provide support to people who are facing problems with gynecological health, because it's incredibly isolating. A lot of people say to me, I don't know anybody who's had a miscarriage, for example, or has endometriosis, but actually I'm so certain that they do, because it affects so many people, but people do not talk about it. So people often seek a lot of comfort in these online forums, and I think that's great, because you want to feel that there's somebody out there. You want to hear what happened to somebody else in their personal story, and that's not something you necessarily get from your consultation. But I think that also, whilst anecdotes can be incredibly helpful and incredibly empowering, they can also be quite problematic, because what is happening to one person is not really applicable to somebody with exactly the same diagnosis, for example. And so often that can cause more concern and cause people to think that they're not being treated correctly by their healthcare professional. It's also problematic because sometimes people unfortunately do have an ulterior motive when they are putting healthcare information out there. For example, are they actually trying to sell you something? There's a lot of people out there, for example, selling supplements, who have a particular dialogue related to gynecological health, which isn't necessarily in line with maybe the advice that we would give in the hospital, but these people are very vulnerable. They're very desperate for information. And so I can see why there is a draw to that. Now, one of the things that I quite like to do on my platform is to create videos. I think that people quite like it because it feels quite personal. It's like a doctor is talking to you. And I recently created a video about adenomyosis. So this is a condition that causes incredibly painful and heavy periods. It probably affects at least 1 in 10 women. It is slightly similar to endometriosis, but it's only inside the uterus. Now, I didn't know until I actually made this video, and this is because people told me, but there's no NHS website about adenomyosis. There's an NHS website with really great information about lots of different conditions, but adenomyosis does not feature on there. And this is something that is incredibly common. So where are people going for this information? Now, what I would say is that I think that a lot of charities are really, really stepping in and giving us access to great information that we can give to our patients. Endometriosis UK, who we've already heard from, are a really great resource, and I probably recommend that almost on a daily basis. I also work with the Eve Appeal as an ambassador. They are the only UK-based charity for gynecological cancers, and they also have a really great helpline, which is so important for people as a great source of information. And then also Joe's Cervical Cancer Trust, and then also the Ectopic Pregnancy Trust, Miscarriage Association, and Tommy's are other places that I frequently send my patients to. And the reason is because I know that there's really great information there. I know that it's written by experts and it's peer reviewed. And I know that people can also reach out to them if they want help, because they run really great support groups. Now, I've had a few comments from colleagues saying, "Oh, why do you bother being on social media as a doctor? You know, is it worthwhile? Should doctors be on social media?" Well, I would argue yes, because I think that, you know, I have demonstrated some of the reasons why it's so helpful. But I also think that if the doctors aren't saying anything, it makes it seem like everybody else who's giving out the information is the person who's right. So I think that we do have something to say, and I do keep trying to kind of dilute out the poor quality and misleading information.
Yeah, no, that's fantastic, and I think well, in fact, I was just going to ask you very briefly: are doctors being trained at all on how to liaise with people over digital media now that it's going to be sort of one of the platforms of the future, I suppose? And you know, I think it's a concern because people will, as you say, be vulnerable. So how do people make sure they're accessing that information? Some of the websites you've recommended, I think that's fantastic. But I suppose the key issue is to check with your doctor too. Is that you know, where we want to sort of head?
Yeah, absolutely. I think that, you know, there isn't really any formal training for doctors when it comes to social media, and there aren't really any guidelines specifically about how we really use it. The GMC does have some very basic guidelines, but it is quite grey. But I think that I think it's really important to be aware of what our patients have access to, and to be able, you know, just having the insight that people are actually probably more inclined to go home and Google something than maybe pick up a leaflet. And I think that, you know, often people, for example, who are coming, I spend a lot of time in the colposcopy clinic where we see people who have abnormal smear tests. Now, there's a lot of information in that letter that you get, but often I feel people haven't read it because maybe it's not really in the way that they want to obtain that information. So I think being aware that people are going online, understanding the kind of things that our patients are reading, what they have access to, but also knowing where we can direct them is just really, really important.
Absolutely. Thank you so much. And the next question, I think, is so topical and crucial. You know, and we've seen this through the COVID impact of the past 18 months or so. And it's about the adverse impacts of racial disparities in the UK's health system, which has really come to the fore. How can health promotion be more intersectional, and why is this so important? So that's for Dr. Jenny Douglas.
Thank you for that question, Lisa. I think it's really, really important. I think that COVID has shone a light on existing kind of inequalities, particularly in relation to racial disparities in health. But these disparities have been there for decades, really, and it's alarming, really, that it has taken a pandemic for us to shine a light on them. In your own document that supports the call for evidence, you know, it says that we need to ensure that we have the appropriate research and evidence, and you know, it states that Black women are underrepresented in the evidence. So in order for health promotion to be more intersectional, and that is to promote the health and well-being of all sections of our society, we need to have intersectional epidemiological data on which to base and develop appropriate and relevant health promotion programmes, policies and interventions. And what I mean by intersectional epidemiological research is a recognition, first of all, we've talked about the social determinants of health, but I think one of the things that has been missed out from that discussion around the social determinants of health is that racism is a social determinant of health. And we need to have some research which demonstrates how kind of race, gender, class, disability actually plays out in Black women's lives. So we need to make sure that the data that we are collecting is disaggregated in relation to gender, race, ethnicity, social class and social disadvantage, and that actually starts to document interpersonal and systemic racism. I think it's something that we haven't wanted to talk about, but it's really clear in, I've been looking at maternal mortality, and everybody will be aware that Black women are 5 times more likely to die in pregnancy and childbirth than white women. And this has been the case for a very long time. And I was looking at a document that was published in 1992, which was from qualitative research with young Black women. And they talked about their experience then. So, 1992, how long ago is that? Nearly 40 years. And we are still seeing this. So we need to have research for both service providers and policymakers, which looks at, the experience of Black women. And I'm talking about Black women, but by actually developing appropriate research processes that involve Black women and women of colour, we will actually make the health systems better for everybody. And that, when I say Black women, I also mean actually we need to do this for all women of colour, for Asian women, for women who are kind of on the margins, for women who are disabled. We really need to make sure that we have intersectional research. And when I say that Black women, that we need the research, we need Black women involved at every stage of the research process. So, in defining the research, in designing the research, in developing the research protocols, in doing the research in terms of collecting the data, in analysing the research, and in writing the research findings and translating that into policy and practice. And as I say, by doing that, we will not only benefit Black women, we will benefit all women. You're on mute.
Here we are, another technological stuff. Perhaps that's something in Parliament as well that we could be asking more about health questions, in relation to what's happening with the intersectional research, what kind of funding is going into that intersectional research, because it sounds like, that's just a huge gap. And I think the past pandemic experience has really thrown that into light, particularly for those people from Black and ethnic minorities, but also, as you said, very clearly from those who may have disabilities, or from women who are marginalised in other ways. So I think that's something that really has to be taken forward, and I thank you for highlighting that once again today. Hopefully we can all be working together on these issues after the meeting. Our fourth question is to Shaista, and it's that we often hear people talking about gender data gaps. We've spoken a little bit about that in terms of intersectionality. This is about when it comes to healthcare. How important is female representation in that research? So, I think we've heard a bit about how important it's going to be in terms of intersectionality. Are we actually even getting women into, leading up in the research in this area themselves? So, a good question for Shaista.
Hi, thank you. And it's good that I've come after Jenny, so some of what I will say will overlap into that. It's absolutely crucial that women are involved, to improve services, raise standards of care, and women need to be involved in all aspects of, designing, delivery, development of, so those voices need to be input at every level, at every decision-making level, in fact. And I feel there's sort of 3 ways of doing that. It's not just, Jenny's talks a lot about research, and I'll come back to that. So research is one, whether it's in-depth researching their experiences or getting them to participate in trials. Then, as Jenny mentioned, that sort of data collection analysis, but also lay involvement, and that needs to happen across the healthcare system. So I'll try and tackle each one. So I'll start off with the lay involvement. If you have really good lay patient involvement at all levels, that is going to actually plug some of that data gap. And I feel when you look at the different stakeholders within the healthcare system, I feel it's inconsistent, and patient representativeness also really varies. And I just want to give an example of what we do at the Royal College of Obs and Gynae, and that's why I didn't say too much in my introduction about what we do. So there we've got an internal strategic group called the Women's Network, and you've got women with diverse experiences in terms of health, but also demographics as well. Then we've got an online panel of over 600 women, again with diverse health experiences, from sort of rare conditions to common conditions as well, and that informs the work. And then last year, the President Eddie Morris set up the Race Equality Task Group to try and look at what factors are contributing to the different health outcomes between women from different ethnic groups. But what I think sometimes happens is, when you look across the health system, is sometimes women aren't engaged, whether it's research or informing policies or whatever it is, or funding decisions, because it's deemed as too time consuming or too costly. But in fact, if you do patient involvement and patient engagement really, really well, it can result in speedy referrals, targeted referrals into the right care pathways, which can result in better health outcomes, save lives. But actually, I think what's not realised is actually a big good business case as well. It can actually result in cost effective and efficient services. So I'm surprised that that's not done there. So, for example, in the Royal College of Obs and Gynae, women's voices aren't just informing, what the doctors do on a daily basis to improve patient care. So if a piece of research is done, it's how can we integrate those diverse voices into that research, which takes me on to the next point of data analysis. So data is collected about women's health across their life cycle, but that's got to be collected in a meaningful way. So you can then do that research, because if you don't do it properly, you can't then break it down, and you need to break it down for the different groups to do the data analysis. So, for example, I've been in meetings where when they talk about Black women as one group, but actually Black African Caribbean women may have different experiences to Black African women, and people don't see the difference. Or even South Asian women, sometimes the experiences may be similar, but in other instances, Pakistani, Indian, Bangladeshi women may have completely different experiences. So it's actually looking at, the socioeconomic factors that play a part in their health outcomes. And I think people are too easy to sort of lump people into neat boxes, even when it comes to the third point of research. So now suddenly there's a lot of activity now around maternal experiences. What are the maternity experiences of Black and Asian women? But again, everyone is just looking at race. And I run a charity called the Muslim Women's Network. The Muslim women are saying to me, well, actually, how about our experiences of our faith? When I'm going in as a Black Muslim woman with my headscarf on, when I'm going in as an Asian woman, my faith can sometimes, I feel, play a part in terms of the microaggressions that I receive. Why isn't anybody looking at that? So now we've actually started, so we've got through the APPG on Muslim women, we've now started the research on Muslim women's maternity experiences, which we're doing it at the moment. It will probably come out in October. So in terms of research, I feel that there's a bit of a barrier in terms of women are not, they need to be involved in the design, the development, as Jenny said, but also participate in trials when you're designing a service or adapting one. But no one explains to them, like, how's it going to benefit women? How's it going to benefit them? Lots of other barriers in terms of costs, travel costs, they may be working, childcare costs. That needs to be built into the research. And then when you come to Black and Asian women, well, they may not trust the research. In fact, if they've got poorer health outcomes, they're going to think, why am I going to participate in this research? So maybe somebody from a similar background to them that's doing the research that would probably gain trust, and they could also reach out to, you know, Black, Asian, minority ethnic charities as well. But again, they need to compensate those charities as they do the women. My charity gets calls and requests every single week from researchers. If we responded to all of those requests, all we would be doing full time is doing the, you know, helping with that research and actually not doing our work. So, you know, people need to really think and build that into the costs at all levels with that kind of engagement. I just want to end by just mentioning the equality legislation. In fact, there's a legal duty to, you know, address those health inequalities and make sure that, you know, all patients have, you know, same outcomes and access to services. And it's not just about giving out information, as Jenny was saying, it's not just about giving out information, and that sort of data analysis, research and lay patient involvement is also going to be key in ensuring that those equality duties are met.
Absolutely. Thank you so much, and that was very, very thorough in how we need to improve this data collection and actually the involvement of those with experience at the front line of developing the systems that work. That's fantastic. Our final question before we move to our Q&A is for Sara at Gorton, and it's about the health for women as it is currently in the workplace. You know, what health hazards are women disproportionately exposed to within the workplace just now, and would a gender sensitive approach to addressing these hazards be important? What would that look like? So a few parts to that question, Sara.
Yeah, and hopefully what people will see when they look at the UNISON submission to the consultation is that we kind of describe the way that women's health is influenced by three main factors. So the social expectations that are placed on women that some of the other contributors have already talked about, their physiognomy that we've already covered in some of these areas, but also influenced by the jobs that they do and how they experience the world of work. So I think I'd like to cover kind of two broad areas today. So firstly, hazards that are particularly associated with the environments in which people work, and I'll try and illustrate that with some examples from my own knowledge of the health and care sector. And then secondly, aspects of healthcare that are associated with employing large numbers of women in your workforce as employers, and try and suggest some of the policy fixes that we would like to see for those. So firstly, looking at hazards associated with the environments in which women work. From my sector, I think there's three really big ones I would like to draw out today. So one is the impact of shifts. So doing rotating shifts, you know, there's a lot of research about the detrimental impact that shift working has on a range of different health conditions. With female-dominated workforce, that's even more pronounced, and we know is an added contributor to stress and anxiety when that doesn't come with flexible working policies that enable people to arrange their shifts around the realities of their own family lives. So what we'd like to see is understanding more of this in workplace policies, ability to monitor hours. We know that lots of people who work in jobs don't just do one job. But there's nothing that brings together all of the information about the different work that women are doing. So even in NHS trusts where you think people have substantive contracts, actually a lot of the work they also do is done through bank work in addition to their contracted hours. And there's nothing pulling that information together, talking to us about, you know, so enabling research into what the total working pattern for those women looks like. Secondly, in our sector, big issue associated with the very physical roles people do, lifting, carrying, you know, huge range of musculoskeletal issues. So proper policy fixes around training, good occupational health service, and fast track referral to good support, physio and other recovery support there. But I think one of the issues that we've really seen come to the fore during the last year is the impact of isolation, home working and trauma and violence. So we'd already had a big focus in the NHS on something called the Blue Light Project, which was understanding more about the impacts of people of traumatic incidents at work and of experiencing violence in particular sector. But the pandemic has meant that more of the women in our workforce have been isolated over the last year. They've been working at home, often in environments that aren't set up for home working, often trying to juggle family responsibilities as well, and that has had an impact. Lots of people as well have been redeployed to different areas and experienced an intensity of work over the last year that has been unfamiliar to them. So what we want to see is lots more consideration of all of those issues before employers set in stone what their post-pandemic workplace is going to look like. We know that lots of organisations are leaping to close offices more permanently and downscale the amount of desk space that they allocate to people. So we think these things just need a bit more consideration. So in terms of hazards that are particularly associated with having a female-dominated workforce, I think there are a few things just to raise here. So menopause, one of those crucial areas where we want to see employers do more to have good workforce policies in there. We want to see recommendations in the strategy about how employers can do better to support women. Secondly, reproductive health, already been touched on in the panel, range of issues that really require better reference to reproductive health in workplace policies, just to avoid triggers for disciplinary action being encountered as a result of issues related to reproductive health and conditions. Better approaches by employers to risk assessment during pregnancy, particularly important as well. I think one other aspect of this to mention in this section is around domestic abuse. And whilst this is not a work-related issue, it does manifest at work for victims. So we want to see employers doing more to make disclosing less terrifying for people who experience domestic abuse, and we want to make sure that it is less likely that employers use sanctions against women who've been going through this because they are enabling women to disclose earlier. I think, though, the one of the top issues for us at the moment that we really want to highlight in our submission is the high and disproportionate impact of mental health issues on women. And that's something that we know has been exacerbated by the experiences of the last year. But roughly, we're looking at 1 in 5 women experiencing mental health conditions compared to 1 in 8 for men. And there are growing concerns about particular groups of women and particular age groups. So a growing number of younger women reporting self-harm and at risk of suicide as well. So we want to see mental health and mental health issues feature very prominently in the recommendations, and better support. I think key for this is starting with training for line managers. So not even half of the women that the TUC surveyed last year said that they would feel comfortable talking about mental health issues at work. We know that work done by Deloitte has shown that there's a strong perception that people fear they will be penalised from disclosing a mental health issue. So that's something we really need to get to grips with. And as other contributors have mentioned, all of these issues have an intersectional issue. So we know that there are worse outcomes from certain health conditions and from some of the issues I've mentioned because of race, class, disability. So all of those issues need to be considered. And I think that in general, what we want to do in the strategy is to see it include health and well-being in the work environment, as well as physiological and biological issues, and consider ways to prevent ill health and promote well-being in the workplace. So I think that's what we would like to see.
Thank thank you so much for such a thorough response there, and we do hope that to see many of these issues in the strategy going forward. Particularly, you highlight the prominence of mental health, and I think that's going to be crucial. We have some questions for the remainder of the session that have come through on the chat. I'll read a couple out and see who wants to answer, have a go at answering them, and then move on to another couple before we finish up. So one has already been touched on, but it's been raised by Baroness Verma, and that's about the onset of menopause. And Baroness Verma does a lot to champion women and girls in Parliament, and also those with disabilities. So she said it's a lonely and frightening experience for many people, menopause, and how do we access support for the hard to reach communities and minority communities on those issues. Perhaps Jenny, if you could respond to that one to start with.
Okay, thank you. It's something that I think has, again, I feel like a kind of long playing record saying, yes, this has been around for decades, but there really is a gap in terms of the information that is available for Black and minority ethnic women about menopause. And I was working in Sandwell in the 1990s, and we actually produced a video for Black women on menopause, because from a piece of research that we did, we found out that a lot of Black women, because of the process of migration, you know, they had been separated from like older female relatives, they didn't have as much contact, and therefore they didn't have anybody to talk to about menopause. And this is still, as has just been highlighted, a really important issue. And so I would like to see the Department of Health actually taking this up and producing some resources for Black and minority ethnic women on menopause, some information that is relevant, that is accessible, and that is appropriate. I recently kind of did a review of work. I wrote a chapter in 1992, and I did a review of what has happened since then. And I was very disappointed that, you know, that this hasn't been taken up. There are a few women who, in the margins of their time, are actually producing menopause information and have websites. But really, we need a concerted kind of national effort around this.
Brilliant. And Anita, is that something that you've been speaking about online then, and liaising with women more generally on? Is that an issue that comes up regularly?
Yeah, definitely. I think that menopause is such a huge topic, and I think that there is such a great conversation about it these days. Often I think a lot of people say, well, my GP didn't talk to me about that, but I think that we're actually putting quite a lot onto GPs. I don't think that necessarily, you know, we can't expect everybody to be an expert in the menopause, and I think that we need to get more people being referred into secondary care. We need to open it up. I think that the British Menopause Society has got a lot of really great information. I think they do a really good job, but again, it's just making people aware that there is that information out there. If there are any doctors in the audience who want to learn more about it, I think that the British Menopause Society has got a really great educational section. But I think it is about sort of people in their own communities going out and you know, making people more aware of it. And I think often, you know, people want to often learn from somebody that they feel they identify with, and so maybe somebody from a Black community doesn't feel that they identify with me, especially, you know, I'm quite young, I guess. I haven't been through the menopause. Maybe someone doesn't want to hear about it from somebody who's never experienced it as well. So I think that there are so many of us out there who can really work together, and I do feel that, you know, GPs are doing an amazing job, but we can't expect them to be shouldering all the burden.
And do you have anything you want to add, Shaista?
Yeah, I mean, I think the first problem is not waiting for the women to come and ask for help, is reaching out to them. And actually, if we see a lot of the imagery around menopause, you do see actually it is actually white women. The imagery is of white women. So I think we need to change that. So just a quick example. So recently, actually, we did a podcast, the Royal College of Obs and Gynae partnered with, for example, Royal College of GPs, and did a podcast, but it was actually a Black woman's experience of the menopause. And my charity, the Muslim Women's Network, we also did a podcast on our MWN hub, and that was Muslim women getting together talking about menopause. So to reach women, it's partnering with those, Black and Asian minority ethnic charities. I spoke to Jewish women's groups recently, a few months ago, and they said actually Orthodox Jewish women are unlikely to talk about menopause. So how do you reach them? What are the information channels to reach them? So I think it's about being proactive, reaching those women, but really it's about partnership with the third sector to reach those women with the right information.
Yeah, making sure that no one's left behind in this information dissemination. And there's a particular question about, we'd spoken a bit about non-invasive diagnostic methods for endometriosis. So I was wondering, Rebecca, if you want is there research happening there?
I'm just sort of starting to get involved with our research. So I'm not sure if there's a research group, as I mentioned in the chat, but I will look into it. But I was actually contacted in the last couple of weeks by a medical device company who are doing some research in that area, and they're hoping to develop a non-invasive method. And I'm going to set up a meeting with them next week. So I haven't got anything to say on that at the moment. Okay. But it is important because there is also the issue of some women don't want a laparoscopy. Mm-hmm. So then are they considered to, then they don't have a confirmed diagnosis. So do they get put on the right care pathway? This was raised by one of our clinicians in preparing our response to the women's health strategy. So what do you do with women who you're pretty sure have got endometriosis, but the only confirmed way is a laparoscopy? So there's another question there. But yeah, if someone could invent a non-invasive method, that would be great.
Well, there we are. But is that something that government should be supporting in terms of research funding moving forward?
Definitely. There's a lot of research gaps in endometriosis. We still don't even know the cause of it. So without knowing the cause, it's unlikely that a cure can be developed, because there is no cure for endometriosis at the moment, although there are, various treatments to sort of manage the symptoms. But they're all secondary, at least in the UK, they're all kind of like secondary. They're things like contraceptive pills or, pain relief that are designed for other conditions, but also used for endometriosis. So there's a gap also, another research gap in terms of the effectiveness of different treatments of symptoms. So we know anecdotally some work really well for some people and not for others. But there is a lack of research there as well. We're going to be asking the Department of Health to make endometriosis a research priority, which may not surprise anybody.
Fantastic. Well, we'll watch out for that, and certainly encourage through the Health All Party group that MPs would support that call. The final question here that we'll manage to squeeze in is about contraceptive choices in young women, and being able to get accurate information and what's happening online there. So it would just be very briefly, if you want to start, Anita, about what's happening online, if there are particular sites that are recommended by medical associations, etc., that young people can go to.
Yeah, I think that the topic of contraception is a huge one, because I noticed this conversation online where people say, well, I don't know what options are out there. There's so much information out there, but people don't know where to get it from. I know that one of the people in the audience is from the Lowdown, which is a really great website where people can give feedback about different kinds of contraception. But I think also that it is difficult, because when you hear somebody who says, oh, well, actually, I really didn't like that, it was horrible, then it does put people off, and it can be really difficult. I think that we need to, I mean, there's such a lack of funding when it comes to contraceptive and sexual health services these days, and I think that ultimately it does need to be one-to-one. I think that online services can be really, really helpful, but you do need that tailored one-to-one with a healthcare professional. We're not all, you know, we're not an algorithm, we're individuals. We can't just pick by a flowchart, if you see what I mean. And I think that that's where we're really missing out. And I think that also having those kind of like one-on-one situations with a healthcare professional, you can give so much more opportunistic information and so much more opportunistic health promotion than just simply looking at a website.
Yeah, so the message is making sure to contact a healthcare professional, and you know, I suppose online could supplement some of that, but
yeah, absolutely. And I think, you know, one of the benefits of the pandemic is that I think we are going to be looking so much more to telemedicine, and I think it's absolutely great. It just reduces some of the huge barriers, but I do think it has to be personalised and tailored. Absolutely, thank you. And we don't have time, but I'm sure that those issues will also resonate very much with ethnic, Black and minority ethnic communities as well in coming forward. So that's more work for government to be looking at in the strategy. And I want to thank everybody who's taken part today. It's been a fantastic discussion, and certainly will feed forward into the consultation. To thank Shaista, Anita, Rebecca, Sara and Jenny, and everybody who has been today, and of course to thank Whitehouse Communications who are excellent in terms of bringing together these conversations and making sure in terms of strategy and policy development. So thank you to everybody, and I want to wish you an excellent rest of your day. And it's even, the sun is shining up in Scotland, so I hope it's also shining where you are, and that you can have a lovely afternoon going forward. So thank you so much.
Thanks.
Thank you. Bye.